Morning, everyone. Welcome to today's Research America Alliance discussion. I'd like to thank you for joining on Zoom today and for your partnership in the Research America Alliance. Starting off with some housekeeping, if your organization is not a member, I hope you'll reach out to Kristen Furlong, Director of Membership and Development, whose email is in the chat for more information about our alliance. For today's discussion, please type your questions into the Q&A box or the chat, and we'll get to them during the audience Q&A portion at the end of today's session. Today, we are excited to be partnering with Keck School of Medicine at the University of Southern California to discuss research on aging in low and middle income countries, how it relates to aging populations in the US, and the need for a stronger global research agenda on aging. It's my pleasure to introduce Dr. Carolyn Meltzer, Dean of the Keck School of Medicine at USC. Dean Meltzer, the floor is yours for your opening remarks. Thanks for being here today.
Thank you, Savannah. On behalf of the Keck School of Medicine of the University of Southern California, and with thanks to our wonderful partners at Research America, I have the honor of welcoming you to today's event on the need for research in aging. Although today's event focuses on aging in low and middle income countries, I want to begin here at home. In the United States, our population of people over 65 is growing larger every year and demonstrating a wider variety of needs than ever before. From care for multiple morbidities to home and community-based services to age-friendly communities to emergency preparedness and disaster relief, as we in Los Angeles so painfully learned during last month's wildfires. The good news is that we're not alone in striving to meet these needs. Other countries, regardless of income level, are also adapting to population aging and have lessons that we can learn from. Challenges such as training and developing a care workforce can best be addressed through cooperation with countries that also have growing care needs and shrinking pools of caregivers. At the University of Southern California, we're excited to have a new campus in Washington, D.C. that gives us the platform to debate and address these very challenges. This campus has strengthened our partnership with Research America and brought us here today. Under the leadership of Jonathan Cohen, the Keck School of Medicine and the USC Institute on Inequalities in Global Health are partnering with groups like Research America to exchange and amplify knowledge on how to address society's most pressing health problems. Research is the foundation of this enterprise, and not just biomedical research, which is close to my heart as a neuroradiologist who seeks to understand the brain's structure and function in later life. Equally needed is research into the social determinants of healthy aging, the non-biological factors that address whether longer lives translate into healthy lifespan, factors such as access to health and social care, the physical and social environment, and laws and policies. We gather at a time of significant public attention and concern over the future of biomedical research funding in the United States. This concern makes today's topic even more important. Healthy aging is an issue that affects us all and is a prime example of why a bold health research agenda is needed in the 21st century. I now have the pleasure of turning the proceedings over to my USC colleague, Professor Jonathan Cohen.
Hello, everyone. Thank you, Dean Meltzer. My name is Jonathan Cohen. I have the pleasure of serving as a professor of clinical population and public health sciences at the University of Southern California, where I am also the director of policy engagement at USC's Institute on Inequalities in Global Health. And I'll be your moderator for today's Alliance discussion. I am so honored to introduce our two distinguished guests for today. First, Dr. Rosemary Morgan is an associate research professor in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. Welcome, Dr. Morgan. And joining her is Dr. Jepchirchir Kiplagat, a lecturer in the Department of Epidemiology and Medical Statistics at Moi University School of Public Health, and a dedicated researcher with AMPATH at Moi University in Kenya. Welcome, Dr. Kiplagat. Both of their bios are in the chat. Doctors Morgan and Kiplagat will be discussing their own research on aging in low and middle income countries, how that relates to aging populations in the United States, and the need for a stronger global research agenda on aging. So to start us off, we have about 30 minutes for discussion. So Doctors Morgan and Kiplagat will be keeping their answers relatively brief to get into the discussion format. But I want to begin with a question for both of you, perhaps starting with Dr. Kiplagat. We are, of course, witnessing a phenomenon of population aging, changes to the very age structure of populations, both in the United States and around the world. So I'd like to ask each of you, what has your research taught you about how healthcare investments and systems might need to be reformed in order to address this changing demographic reality? Dr. Kiplagat. If you could unmute, please. Yeah.
So I'm actually talking to myself. Sorry. Thank you so much for that question. And my research really on aging in low and middle income countries has particularly focused on older people living with HIV. And this has highlighted several critical areas where healthcare investment and systems can evolve to meet the needs of aging populations, both globally and also in the US, I believe. First is that integration of care is essential. Aging is often accompanied by, multiple comorbid conditions, yet, health systems, both LMIC, I believe, and also in the US or high-income countries, are often largely designed for single disease management. And, if you look at the AMPATH program that I work in, we have observed our older people living with HIV having a high risk of, developing hypertension, diabetes, and if we then integrate this care for these older people, we have observed, improved experiences among older people themselves, but also improved health outcomes and better continuity of care. Two is health workforce capacity needs to be strengthened. Most healthcare workers generally continue, and especially within the LMIC, are not adequately trained in geriatric care or managing multimorbidity. And therefore, that component of training. I want to believe also in the US, in as much as we have geriatric, care service providers, there are not as many. And therefore, investing in this workforce, especially the training or even just task shifting component, can help optimize care delivery. Third is also the issue about, shifting from disease-centered to person-centered care delivery, where we are focusing on an individual and therefore looking at that individual as living with multiple conditions as they age or they are at risk of developing those conditions. So looking at, person-centered care and promoting that, including beginning to screen for certain chronic diseases or screening for geriatric conditions as people age, help, identify issues early enough and also promote early management for improved care delivery. Lastly, I would say the need for, a global research agenda that really focus more on funding research on aging. A lot of this funding, of course, would be found in the high-income countries. We still see low-income countries facing challenges in terms of funding, and particularly funding for aging-related research. I'll leave it at that for now. And yeah, take it back to you.
Thank you.
Thank you.
Thanks so much. And speaking of what the US can learn, one of the things that you have taught me is that a rural area in the United States might not be all that different than parts of sub-Saharan Africa in terms of the number of people with geriatric training per population of over 65. And that also teaches us that opportunities for healthy longevity in an aging society are not equally distributed, depending on where it is that people live and their access to healthcare. Dr. Morgan, same question for you. What has your research taught you in this area?
Great, thank you. And thank you for having me here with you today. I mean, you're absolutely right that we are currently experiencing a huge demographic shift, I think particularly more so in low and middle income country contexts, and this is due to global health, public health, health systems interventions, HIV care, is a big part of that is allowing people to live longer lives. And there's going to be significant challenges alongside this, and I'd first like to also, think about what do we mean when we talk about older populations. My own research actually defines them around 45 plus, which you might think, wow, that's young, that's not old, and it's not really. But from a research perspective, when we're, talking about older persons, a lot of people are missed 45, 50 plus, and sort of thinking about the unique needs. My own work focuses on particularly older women's health needs, when women are going through perimenopause, menopause, postmenopause, and upwards, and that happens 40, 45 plus. And a lot of healthcare needs, a lot of unmet healthcare needs from that age group onwards. So when I say older persons, and I'm pretty mentioned that I'm in that age range myself, that's what I'm talking about. And I'm also, thinking about the specific needs of women 40 to 50, 50 to 60, 60 to 70, thinking about that life course approach too. So when thinking about the numbers, and the data that we have available, currently 75% of people aged 50 and older are in low and middle income countries, and 53% of those are women. That's expected to rise to 82% by 2050, with again around 53% being women. So we're seeing a huge shift, a huge demographic shift, that health systems are going to have to meet those needs. And I've mentioned that my research specifically focused on women's health. What you asked, what do we need in terms of healthcare investments? I think we really need to think about the specific sex and gender needs of both men and women as they age across the life course, right? And so what are their needs, within the health system at those different age categories? Women's health, when it is prioritized, it's often in relation to maternal and reproductive health. Women's health is often viewed vis-a-vis their reproductive function, and when that ends, we see a huge gap in care. And I want to uplift everything Dr. Kiplagat said in terms of the need for integrated care. So important, moving away from disease-specific care to, integrated, people-centered care that looks at a whole person, their health and care needs. They're thinking about their well-being, and the need for, healthcare worker training in these issues, not only in geriatric care, but again, women's specific care needs and men's specific care needs across the life course. So I think, health systems are going to need to rise to meet these challenges, and if they're not, we need to start stepping up now, because we're not going to be prepared, when we see these huge influx of people that are aging and living longer lives, and rightly so. But they are going to be able to need to access appropriate care. And we need to make sure that we have appropriate research, to identify what that care is, to identify those needs, to ensure that we are strengthening health systems to meet those needs.
Thank you. Thanks so much. Just broadening out from the formal health system for a moment, Dr. Meltzer opened our event today by noting that healthy longevity is a function not only of biology and health systems, but of social determinants. And in that vein, I wanted to ask you, I'm coming back to you, Dr. Kiplagat, in a context where the global population of older people is expected to double in the next 3 decades, what are some of the broader societal implications of this, particularly in contexts like Kenya?
So, really, sorry, I have not a toddler here, but it's coming around. Yes, as you rightly mentioned, the rapid growth of global population is for sure aging, and we are in LMIC particularly. There will be for sure an increased risk, an increased burden of non-communicable diseases. And because this is, aging is associated with the rise in chronic conditions, hypertension, diabetes, cardiovascular diseases, dementia, and many others. And health systems within, LMIC remain focused on infectious diseases and continue to leave this gap in screening, prevention, and managing these NCDs. So there has to be, an investment in these countries to ensure that they are escalating, the healthcare systems to incorporate the increasing burden of NCDs. Beside that, it's, the challenge of the resilience in the health systems themselves. Thinking about them, a lot of our health systems are not equipped to, for these complexities that older people develop as they age. And primary healthcare services then that are often fragmented, lacking integration between infectious diseases and chronic diseases, will have to, come together and begin that integration component. Otherwise, then, we face the reality of, being having health system that is not as resilient to just support, this growing need for chronic diseases. In LMIC, and let me be very particular, is that older people, as they grow, they of course move out of the working age. And retirement age in Kenya, for example, is 60 years. 60-year-old is somebody who can still really do a lot. But because, the system just retires them, means that these are people who will no longer have regular income. And not having regular income then means that the pension system that is not even sometimes, very effective, begin to, be burdened, and therefore, relying on low income jobs because you're no longer in a formal employment, and family support can strain, family, constrain family economic impact. And I say that because most of family members would take care of the older, parents or older or aging family members when they grow old. And as they do that, remember, then it means this is somebody who has to stay. They're no longer working because then they've gotten to their retirement age. And if they're sick, you have to take care of their healthcare. That is strenuous in its own in terms of the economy. And I feel like those are some of the things that continue to increase and impact, LMICs as we see this population grow in numbers and the demographic shift that we continue seeing. Thank you.
Thanks. No, I want to jump in and ask Dr. Morgan, do the challenges that Dr. Kiplagat is describing, do they differ or not from what we're seeing in the United States and high-income countries? And what might the US and other high-income countries learn from the LMIC experience?
Great. Well, I think there are definitely similarities and challenges to across contexts, across high, middle, and low-income country contexts. I think, you know, the rate of population aging is a challenge. That's a key difference between contexts. With where we see a much higher or an increased rate in low and middle income countries. That means a lot of the, you know, the resource or health systems infrastructure, or other social systems infrastructures need to rise up and support, maybe develop systems that weren't there to begin with. The health and care needs, we do see very similar needs across high, middle, and low income country. I think the issue is whether those needs are met or not. So that the rate of unmet needs, I think, is greater in low and middle income country contexts. And again, my work focuses specifically on older women. You know, and older women tend to live longer than men, or women tend to live longer than men, but do tend to live more of their life in ill health, you know, or in disability compared to men. And they need care related to, you know, outside of maternal reproductive health, related to menopause, related to sexually transmitted infections, mental health, chronic conditions. There's many different types of chronic conditions. And again, it's the unmet need, I think, is quite significant. Thinking about resource availability, I think, is what resources are available to meet those needs, and are there any? And I think with shifting funding and support, as we're seeing right now globally, that's going to be changing and shifting. What does that mean for countries being able to provide that support in, you know, for their populations, for their aging populations, and to make sure that support there, not only health, but social support, as Dr. Kiplagat said. You know, what does this mean for thinking about care within the home? We know that women are more likely than men to provide care, both for children and for elderly parents. What does that mean for, you know, as their parents and parents-in-law retire, need to stay at home? Who's providing that care? Who's providing that support? What does that mean for their own, for women particularly, their own careers and livelihoods? You know, so there's really huge, you know, implications here that we do need to consider. You asked about lessons learned. I think there's always lessons to be learned across contexts, whether that's low and middle income country context, us learning from there, and or low and middle income countries learning from high income country contexts as well. I think when you have resource limited settings, you know, community care structures often become really important. And I think you mentioned, Professor Cohen, you know, that sometimes we see there's a lot of similarities in rural areas of the United States compared to other areas in countries like Kenya. And what can we learn from sort of some of those community-based approaches? What can we learn from organizations that have been doing this work for a long time, like Help Age International, for example, is an organization that's been doing this work for a long time. What we learn from the support that they're providing, you know, from on the ground community-based structures as well. I think, again, there's learning that's needed across contexts, both bi-directional learning. I think that, you know, I think hopefully as populations continue to age in low and middle income countries, that health and other social support systems would be able to rise and meet those needs, and that we'll be able to learn as they do so from those contexts.
Thanks, Dr. Morgan. I actually want to ask you a follow-up and jump to a question I'd been saving for later. You've alluded a couple of times to this profound gap when it comes to older women, which you are defining as 45 and up, beginning with perimenopause. And indeed, so much of the global women's health research agenda is through the lens of reproduction, and to the extent it's through the lens of sexuality more broadly, that's often the sexuality of adolescent girls and women of reproductive age. What's it going to take? How does the research community need to change in order to embrace a view of women's health that goes beyond reproduction?
Oh, that's a big question. I wish I had an answer, a specific answer for you. What's it going to take? A lot of work. It's going to take a lot of work. You know, we just lack data and information. I mean, the demographic health surveys, whose future is even in question right now, but ended at age 45, right? And that for the most part, there's some that include questions for older populations, so not just women, but men too. But on the whole, ended around that age range and really focused, you know, a lot of women's health specifically focused on maternal health, reproductive health. So there's just huge gaps in things that we don't know. And this is even in high-income countries, there's big gaps. Thinking about when women's health is prioritized, it is often in the realm of maternal health, reproductive health. I think there's historical reasons for this. Thinking about there's certain diseases that affect both men and women, but might affect them differently. And the response needs to be different because of biological sex differences. But we just don't have the data or research because women weren't necessarily included in clinical trials or other research studies, or when they did, gender sex specific questions weren't asked or data wasn't disaggregated, so we weren't able to find. So what does it take? It's going to take data. It's going to take, specific research focusing on the unique health needs of both women and men across the life course, right? There's this saying in sort of the monitoring and evaluation world that you sort of measure what you treasure. So, or you treasure, I could even flip that, you treasure what you measure. So, you prioritize issues that you have data on. And just because you have a lack of data doesn't mean it doesn't exist. So we need to make older women's health less invisible. We need to have, do the survey. We need to collect the data, find out what those health needs, care needs are, to be able to really understand and provide the support and services that is necessary. We need funders to step up and provide, the funding for this type of work as well. Because without the funding, we're not able to do the work and to do the research. So we're not going to have programs. We're not going to be able to have appropriate health systems unless we really understand what older women's health care and health needs are.
Thank you. Thanks, Dr. Morgan. And Dr. Kiplagat, I want to stay on this topic of older women and ask you in particular about the intersection of older women and HIV, which is something you've seen a lot. How can the research community better address that issue, whether it's the needs of older women living with HIV, at risk of HIV, affected by HIV, etc.? Yeah.
I can't overemphasize what Dr. Morgan did mention on data and the fact that you need data to be able to show the impact over time. And the fact that we have limited data on women, on aging women for that matter, means that we are not, or we do not have the capacity to be able to, do the analysis. We've seen in LMIC, the WHO study on global aging and adult health, the SAGE, it's provided some insights, but there's a lot that remain understudied or uncovered, and particularly issues related to hormonal and metabolic health for women, and particularly women who are living with HIV. Other than the long-term use of ART, we've seen women living with HIV having the risk of bone loss, cardiovascular complications for that matter, insulin resistance, And if this is not studied, and if this is not even screened or managed within the HIV clinics, then we see a missed opportunity for early intervention for these, older women as they grow. So, and the second thing is that with menopause, again, mental health conditions, depression, issues to do with anxiety, cognitive decline, and a lot of that can actually be, exacerbated by menopause-related mood changes. And when these mental health issues combined with stigma that we continue to see a lot, we see women really suffering social isolation or loneliness. And those are some of the things that are less reported, no one, rarely screened, and as such have a huge impact on these women who are deemed to be strong, and can be able to maneuver, can be able to stay stronger for others who actually they are managing. So expanding where I say mental health and cognitive aging in older women who are living with HIV would help, and basically developing, say, a gender sensitive interventions that focus on women and with women, older women who are beginning to, suffer these menopausal related issues would really provide a better way to manage older women. I mentioned stigma, and I mentioned stigma because HIV continues to be a stigmatized condition, even 40 years down the line. And as it does, and especially within the LMIC, older women who are now beginning this menopausal or peri or postmenopausal stages can be very, as I mentioned, isolated, can live lonely lives. And as a result of this, if the healthcare systems that we have in place cannot be able to support and handle this in a very structured way, we see older women living unhealthy lives. Yes, they live longer, but then that longevity is unhealthy in the long run. So thinking through these concepts and developing gender sensitive interventions would likely then focus on just not only women but also men in their own areas that they also suffer, particularly within LMIC, and I believe this also applies to high income countries as well. Back to you, Professor Cohen.
Thanks. I have a couple of questions about the political context for this discussion. Obviously, very dynamic, and just invite you to comment to the extent that you are able. But one dimension of the political climate in which we're having this discussion are certain statements that favor chronic disease funding and interventions over infectious disease funding and interventions, which is a really interesting thing to consider when you think about people with HIV, an infectious disease, which functionally, I would argue, is a chronic disease when managed, growing older and developing multiple morbidities. So, Dr. Kiplagat, maybe starting with you, how do you interpret this potential shift? Is it an opportunity? Is it a false dichotomy? How can the research community adapt to this signal of greater investment in chronic over infectious disease funding and interventions?
Thank you, Prof. Cohen. I think the shift in funding priorities towards chronic disease research present both, challenges and opportunities for the global aging research agenda, and specifically looking at adaptation and how research communities can adapt to this. I look at opportunities in the intersection of, infectious and chronic diseases. Aging population, basically in both, LMIC and even just in high income countries, are increasingly experiencing chronic diseases. But in LMIC majorly, what we knew HIV as an infectious disease has become chronic disease over time. And therefore, looking at this and using even my research on HIV among the aging population, we've seen how multimorbidity complicates care, yet health systems, of course, continue to remain siloed. So if we have to, we need to position research at this intersection to ensure that we continue investing both in infectious disease research while also aligning that to chronic disease priorities. Again, looking at HIV and what, as people age, these chronic disease begin to develop. So if we have these healthcare systems that have developed to focus on infectious diseases, we aligning that to integrate the chronic disease component would really be a key thing in global aging research agenda. 2 is leveraging implementation science, and as we focus on specific conditions, chronic diseases, for example, majority of our healthcare systems still struggle to understand how best to tailor care to aging population, or yes, to basically aging population. And when you look at this, there have been models of care that have been developed in small scale. So looking at implementation research, for example, and leveraging that to learn more about how to best manage, chronic diseases can help us, or would be something that may appeal funders out there to prioritize, research that is looking at not only just infectious disease models that we've seen, but also looking at how these models can also be scaled to also offer care for chronic diseases. I would really talk about strengthening interdisciplinary collaborations, because I think by fostering collaborations between experts working in infectious diseases and those working in chronic diseases, and just not that, plus even health economists, because those are people that would always just do research that would help us look at certain ways that we do things and be able to evaluate those, whether they are cost-effective and whether we need to scale all that up. So I think that interdisciplinary collaboration is something that funders would look at and in a more favorable way. So forming multidisciplinary research teams that bring together expertise from infectious and NCD, and also looking at social determinants of health, for example, might also what I would say be something that would be appealing, to funders out there to look at how best to just, offer the funding. Yeah.
Really, really powerful ideas. So I have so many more questions. I'm going to ask one more for each of you before we open it up for Q&A. And it's about another dimension of the political climate. And that, of course, has to do with the funding climate. And Dr. Morgan, I'm going to start with you. My question is, it's not an easy one, but it's a necessary one. How can researchers continue to make progress, continue to collaborate on global aging related research initiatives under such tight budget constraints if funding from research agencies is cut?
Yeah, that's a huge question, and I think we'd all love to know the answer, to that. Those of us that, whose research really relies on funding from different donor agencies. I think we have to keep drawing attention to these issues. I think the landscape of all like global health research, of women's health research, both here in the US and globally, is going to shift, it's going to change, and to continue to draw attention through our writing, through op-eds, through research articles, to think about different collaborations. Dr. Kiplagat mentioned intersectoral or collaborations is so important, but interdisciplinary collaborations, thinking about how us and as researchers can collaborate with NGOs and other international organizations doing this work on the ground. I mentioned Help Age International. I have a collaboration personally with them, and thinking of, helping them to continue to do the much needed on the ground work that's needed. I think it's potentially, I think we're going to be interested to see how the funding landscape changes and shifts to fill in gaps. I think are we going to see more private donor agencies and foundations stepping in for women's health research, for aging research, for example? I don't know. I hope that we are. I think we did see some of that to some capacity already. I think, though, we have to draw attention to issues because they aren't going to know what to fund unless we are doing the advocacy that's needed. And we need to, as researchers in different academic institutions, need to collaborate. We need to have these collaborations so that we are identifying on the ground needs as well, that we're not just sort of cherry picking what we think is most important, that we're actually working with organizations that are on the ground doing this work to identify what is most needed, so we are prioritizing that work over others. I think we're going to see a shift. What it's going to look like in the next 4 years, 5, 10 years. I think only time is going to tell, but we just need to keep banging our drums, doing the advocacy that is needed, and making sure we're not letting that drop to the wayside.
Thank you. Thanks so much. Dr. Kiplagat, any thoughts from you on the funding question before we open it up to the audience?
I couldn't agree more with Dr. Morgan. And I would say we could also leverage the opportunity to build capacity among our collaborations. You find research intensive institutions can build capacity in less intensive institution in relation to aging research. That's within the strengthening capacity component, and that can be a very low hanging fruit, does not require increased funding or requiring lots of funding to go into that. I mean, we've had virtual the webinars that people could be able to attend to build that capacity. Also leveraging, existing data and infrastructure to conduct secondary analysis can still, offer an opportunity to still understand more on aging and aging research with what we have in place, even without generating new research at these uncertain times, for sure. Yeah.
Thank you.
Thank you.
Well, look, this has been an excellent conversation thus far. I'm going to ask Savannah Sims from Research America to join me back on the screen. I think we have some questions from the audience, maybe some pre-submitted and from today. Savannah.
Thank you so much. Yeah, and thank you all for joining and having such a fantastic conversation. And I think we'll hold you here for another 4 hours. No, I'm just kidding. But yeah, so we have some questions from the audience that I'd like to start with. And thanks again for all of the discussion so far. So one of the questions, this is directed towards Dr. Morgan, but Dr. Kiplagat, if you have an input as well, we welcome that. Given the environment, this is sort of a more general aspirational question, I think, but where do you see the future of women's health aging research in the near future in the US, and how are we going to keep integrating that lens into our research?
Yeah, that's a great question. I think we have a bit of a fight on our hands, to be honest. Like I don't think it's going to be easy. We've women's health, gender researchers, sex differences researchers have done so much work over the last decade to really draw attention to the need for these sort of gender specific lenses to health, not just for women, but for men too, that worry a little bit that some of that work is going to be, it already has been disbanded, and we saw a significant increase in women's health funding over the last 4 years that I think isn't going to be, likely not going to be there anymore. So it's just, it's a little bleak. I'm still in my pessimist phase. I'm going to say, I think I want to get out of that a little bit more, but I think with the dust still needs to settle a little bit. But I do think we have a bit of a fight on our hand, just again, drawing attention to women's health, specific health needs across the life course, I think is going to be particularly important. I think we're gonna see, these changes are happening. We're going to have to rise to sort of meet the occasion of, what does that mean? The types of proposals that we submit look a little bit different, maybe, the specific topics that we focus on look a little bit different, maybe. I still think, global health aging or global aging research is already needed more attention to it. There's already huge gaps in that space. So, and not to mention women's global health aging research. So we just need to keep bringing attention, and looking for those collaborations, thinking about the different diversity in donors as well, and who might be willing and interested to do this type of work. What's it going to look like? I can't say for certain, but I just think our job and our role as researchers is to keep drawing attention to these issues, keep tooting our horns and banging our drums to make sure that it doesn't go unnoticed, that these aren't dropped, these issues aren't put to the wayside and missed. I've already seen huge shifts in the focus and, put on women's health has already shifted in the United States. And I think we just need to come together as a research community to think about what that means and what do we need to do to make sure that this work does get funded moving forward. And that's just going to require a little bit of work on our end to meet sort of the situation where it is at the time being. But again, I don't want us to lose hope. I want us to keep pushing. I want us to keep advocating and pushing for this type of work, which is so needed and important.
Thank you, Dr. Morgan. That actually leads me to one of the other questions from the audience that is both for you, Dr. Morgan, and for Dr. Kiplagat. And I think that we've talked a lot, and you just mentioned in your last answer about the gaps in data that we have surrounding aging research. And I think this is a fun question. And so the submitted question is, I would love to know what research questions the panelists are burning to ask. So, with those gaps in research, what, if you could just aspirationally ask a research question, what would that be? I'm not sure. Yeah.
Okay, I could go Savannah first.
Thank you.
Before I ask the research question, following up on what Dr. Morgan did say about, where do we want to see women health in the future? I think as researchers also, we need to collaborate with, care providers and see how we can, translate the research work that we are doing into the care delivery component. And that collaboration then can allow you know, not waiting for the 17 years for research to, you know, practice translation, but at least can be lessened and can begin to be integrated into the care delivery. But what is this, you know, a question that I is lingering in my mind right now is, you know, research on social determinants of health. There's so many factors that have, you know, an impact on older people: education, poverty, you know, the environment that they're living in, that I think has not been explored as much. That I think it's really helpful to you know, answer that question. What are social determinants of, you know, older people, or what are social determinants of health for, you know, aging population living with HIV, or the general aging population? And that begin to allow, you know, the development of certain interventions that would meet those, you know, needs for those older people. I think social determinants of health is the key thing that I'm, you know, out to look for, and models of care that can optimize, you know, that can optimize care for aging people in general, but specific also to those living with HIV. Yeah.
Thank you.
Oh, that's a great question, and I have so many questions. Like, how do I pick? I like at first just really want to know what are the specific health and care needs of older women and older men, and I want to know that across the life course. So from 40, 45 plus, looking at it from, you know, what is it, from between 50 and 60 or 60, 70, you know, as individuals age, what are their specific health and care needs? And then how can health systems better support those needs? How can we have better, you know, integrated people-centered health systems to meet the needs of aging populations? And, you know, I think that is going to be focusing more on integrated chronic care systems. I think mental health is such a huge issue, and Dr. Kiplagat mentioned it within across aging. And I think our systems aren't set up, you know, really to support that as they should. So, and that goes across the social sector, not just sort of the health system sector. I'm really interested in specific health needs of women, particularly perimenopause and menopause, postmenopause, not only their health, that care needs, and how can the health system support those needs, but what does that mean for shifting identities, particularly, you know, in country, you know, in different across different contexts? You know, thinking about it from a sort of a gender perspective, thinking about the intersection of gender and age, and in the US, also thinking about that intersection of maybe race and ethnicity on top of that. And what does that mean for individuals' identities and for their care needs? Are the health systems, again, meeting those needs as well? First, we need to really understand what those needs are, and then I think it's going to then go in sort of deep dives, you know, into that to really understand how can we better support those needs within the health system, but also within the social systems as well. I mean, I have more questions, but I'll stop there.
Thank you so much. It's always great to hear from the experts about, you know, what they think the most important questions are. So thank you for sharing your expertise. So I think we have time for one more quick question. And I think it's something that we haven't touched on a lot, but there was a pre-submitted question about how we're factoring in the rise of Alzheimer's disease, since, you know, we do have this aging population and other dementias. So, you know, where do you see that intersecting, and are there specific research questions related to that, especially considering care in these aging populations? Whoever would like to start, yeah.
Sure. My mic's still on. I'll go quick. I think I always take a gender lens to everything and would want to know, you know, what does Alzheimer's look like for men and women, what are the similarities, what are differences, and are there specific, you know, care needs of these individuals. I think, it is a really important question. It's a really important issue across the life course. And again, that's why, I keep banging on about the life course approach, because we know Alzheimer's affects individuals when they're older, so a woman or a man who's 70, 80, 90s needs are going to be different than, 50, 60. And it's really important to understand what those needs are. And then again, the integrated integrated approach to health systems is so important, moving away, I think, from these sort of targeted vertical programs to sort of more health system strengthening, that we can have a sort of first point of contact within the health system that takes a holistic approach to a person's needs, and that that the healthcare workers are adequately trained to be able to identify these issues and then refer individuals to the areas that they need. I think there's such, in low and middle income countries, the resource gaps in these areas are huge. Having the healthcare workforce that are specialists in certain areas is lacking. We need more, there needs more training. We need more of these sort of referral specialist systems, but it's going to take time. It's going to take time to build up those systems, but we really need these holistic approaches right from the very beginning in order to ensure that we're building systems that, can meet the care needs of everybody.
Thank you. Dr. Kiplagat, do you have anything to
Sure.
add?
I would say, and from an HIV perspective, because just the same way Dr. Morgan takes the gender lens, I look at it from the HIV perspective. Differentiating Alzheimer's disease and HIV associated neurocognitive decline can actually be very difficult unless you have a very well-established infrastructure that is able to distinguish that. And I see that growing concern, and especially within the aging population that is living with HIV, and how best we can be able to, diagnose these two conditions and be able to manage them separately is one of the key things that needs to, be focused on.
Oh, Dr. Kiplagat, I think you went on mute just a second ago. Yes, sorry.
Oh, sorry. Sorry, I'm so sorry. I was handing over back to you. So sorry.
Okay, well, great. Yes. Well, thank you again for that answer. I think so important. Unfortunately, I think our time here today has come to an end, and I just wanted to, before passing it over to Jonathan, wanted to provide a little bit more housekeeping and, thank all of our panelists here today for being with us, as well as Dean Meltzer. So, before you go, we hope that you can join us for the next Research America Alliance member only meeting, which is going to be next Tuesday, February 25th. So if you are an Alliance member, keep an eye open in your emails for the invitation to that Alliance discussion next week. And back to you, Jonathan.
Thank you, Savannah. Thanks so much. And thank you to the audience for your engaged participation. Before I thank the panelists, I just want to say on a personal note that I've been working in the field of health in sub-Saharan Africa, other low and middle income countries and regions for over 20 years. The fact that we're even having a conversation about how to enjoy health in a longer life is a sign of tremendous scientific progress. Yet we know that the opportunity for that longer life to be a healthy longer life is not equally shared by all. And that comes back to the social determinants, I think, that Dr. Kiplagat, you mentioned, to the gender issues, Dr. Morgan, that you keep foregrounding, to the issues of social determinants that Dean Carolyn Meltzer opened the session by talking about. So thank you all so very much. Thank you, Dean Carolyn Meltzer, Dr. Rosemary Morgan, Dr. Jepchirchir Kiplagat, and especially our colleagues at Research America for convening such an important discussion.
Thank you so much. Have a great day.